Okay, so next slide, please. So we always talk about COVID-19, but we have to understand it's caused by SARS-CoV-2. We had a prior SARS-CoV-1 infection around 2003, 2004. It was primarily contained in China, and we got some around the globe, but nothing like SARS-CoV-2. Now, we use COVID-19 because COVID-19 represents CO for coronavirus, VI for virus, and D for disease. So COVID-19 because it occurred in 2019. But this is a view that we've all seen on every TV channel. And the little red projections on the SARS-CoV-2 virus is your spike proteins. And I am pointing this out to you because the vaccinations basically aim at the um, spike proteins. Next slide. So COVID vaccines, it depends on what day you're reading. Some days it's 56, some days it's 67. And so the number of companies trying to work on COVID vaccines uh, are really, really high. And phase one trials, just to remind you, is that they're testing for the safety and the dosage. Phase two, they expand the safety trials with their dose that they have picked. Phase three is where they have a large randomized double blind trial. And so we get after the phase three trials, then in emergencies, the companies can go in front of the FDA for emergency use authorization. And basically, emergency use authorization, it's been around for a long time, but it was used a lot during the HIV, the AIDS epidemic, because we had people dying here, and the FDA could not approve drugs fast enough, like the European countries and Australia, to give to individuals to save their life. For example, Magic Johnson life was saved because he got a protease inhibitor early and it had not been approved in this country. So they got a lot of pressure to uh, approve drugs faster. Today, we actually have two vaccines that are approved for full use. Next slide, please. So the you usually hear about two types of vaccines. You usually hear about like a protein vaccination and a live attenuated virus. Okay. Live attenuated viruses are rubella and varicella and yellow fever. Um, the the protein viruses or antigen vaccines are like the flu vaccine. Um, the for inactivated viruses, those are like polio and hepatitis A. But in this pandemic, we basically have had two different vaccines that we have introduced that hasn't been in production, in mass production, I should say. So let me see the next slide. Okay, so for your mRNA vaccinations, which are your Pfizer vaccination and your Moderna vaccination, basically they take mRNA, okay? And let me just review this with you. If you remember from Watson and Crick, we have double-stranded DNA. It unwinds and is translated to mRNA. So mRNA leaves the nucleus of the cell and goes into the cytoplasm, and it is translated to a protein. Okay. So the mRNA vaccinations basically are attached to the cells. We think muscle cells, and it goes into the cytoplasm of the cells, and then it replicates and creates the spike proteins on the cell. So the first vaccination you get in the Pfizer trial is basically priming the system. It's making a few of the spike proteins. And then the second vaccine is basically your body is seeing the spike proteins for the second time. And if you remember, your immune system has a memory, and they go, oh yeah, here's that terrible virus again, and they just pour out IgG antibodies. So the big issue with mRNA is mRNA is very unstable. I worked with it 30 years ago, and some nights I just wanted to pull out my hair because breathing on it can contaminate it and cause it to disappear. So what they had to do is find a carrier that would be in the vaccination that could take the mRNA safely to the cell without being destroyed. And this is done by lipid nanoparticles. Now, the second type of vaccination, it actually has viral DNA on the inside of a virus. So it has viral DNA from COVID-19 on the inside of an adenovirus. Now, just so y'all know, an adenovirus just causes your common cold. So it attaches to the cell, puts the DNA in the plasma, and it translates to mRNA and to the proteins, and then the cell explodes, and the immune system sees all the little proteins. Okay, there are actually two vaccinations that are coming down the pipeline. Actually, one's approved in Europe, and it's AstraZeneca, and that uses this technology. And then the other one is Johnson and Johnson uses this technology. Next slide. So there are something called protein vaccines, and basically these are they basically take the virus, they allow it to make spike proteins. They harvest the spike proteins and put them on onto nanoparticles and inject those into individuals. Now, there is one company in Maryland that is actually working on this technology, and the name of it is Novavax. Okay, it has had no approvals thus far. Next slide, please. Now, you will hear about some of the Indian and the Russian vaccinations. Basically, they take the virus and on the inside, they replace the genetic material to inactivate it so it can't reproduce. And the Indian virus and the Russian virus both use these technology, and the Chinese have used this technology. I can't remember, it's like Symbovirus or Symbovac are the names of the inactivated or weakened virus. Next slide. So that's an overview of the type of vaccines that are either on the market or in development. So Pfizer and Moderna are the only two companies putting out vaccines. So before the vaccination was distributed, the CDC had to make guidelines for us to distribute the vaccine in a fair and equal manner. So they labeled it phase 1, A, B, and C, and phase 2. Okay. So the vaccine basically started arriving in South Carolina on the 13th, and MUSC got their first vaccine on the 14th, although it was delayed a little bit. So the very first people that were allowed to get vaccinated were your healthcare workers working on the front line. And then they did the long-term care facility and the 70-year-olds with or without underlying health condition. Okay. They also gave it to long-term care facilities to vaccinate their residents and staff because that is one of the areas that has the highest death rate and one of the highest infection rate. Okay. It was also given to critical, mission critical government employees like the DHEC, the head of DHEC. So the next phase, we are going to be doing law enforcement officers, like our public safety officers, the grocery store people, the teachers, that type of stuff. Now, how fast that comes, we don't know because it depends on how fast we get the supply. So then in late spring, patients 65 and older or 16 to 64 with underlying healthcare conditions can get vaccinated. And then people like Uber drivers and things like that that are still work in the environment. And then phase 2 is expected to come in the summer and fall, and anybody who wants a vaccination will get a vaccination. Next paragraph. Next slide. So you can see one of the big issues has been distribution of the vaccine. So if you recall, I told you mRNA is actually very it's very volatile. It can be contaminated. You have to handle it with kid gloves. So the Pfizer vaccine actually has to be shipped at minus 80 degrees. Okay. And it's like minus 96 or something Fahrenheit, but minus 80 Celsius. Then you can thaw it and put it in a refrigerator for a certain period of time. I think it's 5 days. And then once you put it out, then it really deteriorates rapidly. Now, Moderna's vaccination is actually easier to transport because you can get a -20, and which is that is your normal um, a freezer in your normal refrigerator in your home. Basically, the nanoparticles that they use to carry the mRNA is more stable than the Pfizer vaccine. So, that is why it can be shipped easier. And in the Pfizer vaccine, because it is so difficult to transport, they will only allow you to transport it at in a quantity of like 975 vials, whereas the Moderna vaccination, you can get it in smaller shipments, like 100, and so that is why Moderna vaccinations are going to the they're actually going to the nursing homes for their staff and patients. So currently in the United States, hopefully this gets better every day. We are given 1.3 million vaccines per day. And thus far, we've had 33.7 million people to be vaccinated. In South Carolina, 7.5% of our population has received one dose of the vaccine, and 1.6% of our total population has been fully vaccinated. So, just to give you an idea, to kind of decrease the numbers in our state and in our nation, the minimum we're going to need is 50 to 60% of the population fully vaccinated. Next slide. So, I want to talk about the Pfizer trial first. And you can see why it's called the Pfizer vaccine, because the true name is BNT162b2. And so Pfizer and BioNTech actually worked together. They used each other's resources that they were best at to develop this. And in their phase 3 trial, they used anybody that was greater than 16 years of age, and they randomized 21,720 patients to receive the vaccine, and then they randomized 21,728 patients to receive a placebo. The dose was administered 21 days apart. The range was 19 to 23. And the most common side effects were headache and fatigue. Less than 1% of their population had severe systemic reaction, and the severe systemic reaction was defined as a fever greater than 102 point something. Now, the side effects are more common in the young people than in the older people. And the vaccination was 95% effective at preventing COVID 7 days after the second dose. Next slide. To me, if you have any scientific mind, this graph should be just displayed in your office and all around, because this is where the rubber meets the road. Okay, so if you look at the days after dose 1 on your y-axis and your cumulative index percentage on your x-axis, what happens is that when you have no vaccine, That is represented by the blue line, and when you have a vaccine, it's represented by the red line, okay, in the large graph. So if you see on the blue axis, you'll see darker dots, okay? Those are severe cases of COVID. If you remember, the CDC defines them as mild, moderate, severe. And so those are the severe cases of COVID. If you look on the red line, you can see that there is only one case of severe COVID on that line. Now, in this trial, there was no, um, there were actually no deaths, okay? But you can see that even after the first dose, there's a significant variation in it splits after 7 days. Next slide. So the Moderna vaccine, which again is the Moderna vaccine is mRNA 1273. That's the name of their vaccine. And they basically did phase 1 and 2 trials. And just so you know, that in emergency use authorization, you can combine phase 1 and 2 trials to get things going to phase 3 faster. So they actually picked anyone that was 18 years of age or older. They randomized 14,550 patients to the vaccine trial. To the placebo trial, they gave the meningococcal vaccine, and it was 14,598 patients. The dose administered, the 2 doses, it was administered 28 days apart. And again, the most common side effects were headache and fatigue, and obviously a sore arm for both trials. And the reactions were more severe in the less than 65-year-olds than greater than 65-year-olds, and their efficiency was 94%. Now, Pfizer was 95, Moderna is 94. Because sometimes people will ask you, which vaccine should I get? Next slide. So this shows you the number of COVID cases. The purple line is the placebo, and the red line is actually the mRNA. Okay, so you can see at 30 days, since randomization, your line split. Okay, next, they didn't look at they looked more at the incidence and didn't look at whether or not you got more severe cases. The other thing that they did in the Moderna trial was they looked at whether or not the vaccine was better in women or men, or blacks, whites, Asians, Indians, whether or not it was okay effective in obesity and that type of stuff. For the most part, every group that they looked at, the vaccine had the same effectiveness. Okay. Now, some people, some groups, like men, was slightly better than women. Whites were slightly better than blacks. Um, I can't remember if they were statistically significant, but when you looked at the numbers, they were slightly different. Now, Pfizer did not look at that. Next, and the split that Moderna used was less than 65 and greater than 65. Okay. Next slide, please. The side effects. Basically, these are the side effects after the first dose and systemic adverse effects after the second dose. The first one is just basically showing the injection site, people who had reactions at the injection site, and the second one is basically showing whether or not they had like a headache or aches or low grade fever. Next slide. And you can see that the symptomatic COVID cases in this group was 11 and in the vaccinated group, and there was no severe COVID. They didn't look at moderate. Okay, next slide. So there's some limitations to the mRNA study. There's only 2 months of follow-up, and their endpoints was whether or not you got symptomatic infections, and so they didn't look at to see if people were asymptomatic carriers, and therefore, this is why we still have to wear the mask if we're vaccinated, and they don't know exactly what to do with people who missed the second dose. Next slide, please. This is just a comparison between the Pfizer and Moderna vaccine. I've pointed out the storage requirement, the purchase order, and neither one of them were looked at in pregnancy or lactating individuals. Moderna completed their animal studies in pregnancy and found no problems. The Pfizer one did not complete their animal studies for pregnancy. Next slide, please. So the AstraZeneca is basically a DNA vaccine. You get it in 2 doses, and the efficiency of that vaccine is approximately 70%. Now, it uses a chipmunk adenovirus as its vector. Next slide, please. So this is the name of the Johnson and Johnson vaccine. I like AD26 much better. It's adenovirus 26 vector is why it's AD26. Again, it's a DNA vaccine. I should say vaccine instead of virus. And it is different from AstraZeneca in that the vector's different, but it is only a single dose, and they didn't look at how often it prevented COVID, symptomatic COVID. Their outcomes are moderate to severe COVID, and what has been released thus far says that it's approximately 60 to 70% effective. Next slide, please. Now, we all get these calls about, oh my God, these bad coronavirus variants. The one on the left is basically the novel coronavirus. The one in the middle is actually a picture or cartoon of the British coronavirus. And the one on the right is a picture of the South African variant. What we do know, or what we think we know, is the 2 variants on the right actually have a 50% more infectivity rate than the original coronavirus. And so, whether or not our vaccines actually cover the spike protein depends on the formation of the a spike protein on the British and the formation of the spike protein on South African. And then there's a spike protein, there's another one, there's a Brazilian variant. Now, they took antibodies that we make to the vaccination and they mixed it in a test tube with the British variant. And it appears that in vitro, the virus is neutralized. Whereas the same thing didn't happen in the South African version. There was some neutralization, but it wasn't as good as the British. So people's going to ask you, does the vaccine cover those new variants? So I would just tell them that we're working on that and we think that it's going to provide some coverage on most of the variants. Next paragraph. I mean, so next slide. So the next question we get a lot is, do I get the vaccine if I've had COVID? The answer to that is yes. They recommend that you wait 90 days to get the vaccine after you first were symptomatic for COVID. The other question that we get is, oh my God, I got my vaccine yesterday and I tested positive for COVID today. What should I do? Should I wait for my second vaccine? And basically, this may change in the future. They might say, oh, you need to wait 90 days. But currently, what we're doing is if you are 10 days out, when you when it's ready for your second vaccine, then we give you the vaccine. But if you're not 10 days out, so you could come out of isolation, we do not give you the vaccination. We say wait 90 days. And again, this really isn't based on any science. This is expert recommendation. Next slide, please. So, how can I tell if I'm immune? Should I get the IgG antibody test? So I will just tell you, you need to know what you are doing if you order that immune test, the immunity test, because there's actually two different ends of the virus. There's like an NN and there's an FN, and some of the vaccines test the IgG to N or F, and some can test for both. Like even if I'm immune, I got the antibodies. Our test at MUSC will not actually determine whether I'm immune or not because it only picks up natural immunity. Next slide. I think that's the so last but not least, I've waited here and I promise I didn't mean to talk this much, but what should we tell pregnant women? So the day after the vaccine came out, we got tons of calls in our office. And basically, SMFM and ACOG hurriedly made a very good review. And basically, they said that if you're pregnant and you have a high risk for COVID, then you can consider getting vaccinated. That there is nothing in the vaccine that should affect your pregnancy, but it hasn't been tested there. So the WHO came out at the end of last week and said it shouldn't be offered to pregnant and lactating women, but SMFM and ACOG really came down on them and they got together. And so WHO is actually now changed its stance. So when I'm talking to a pregnant woman, I basically ask, what is your risk factor? You know, if you're an ER doctor working every night with COVID positive patients, I think the vaccine is actually safer for you than getting COVID itself because the number of people dying from COVID is about 1.8%, and young people can die just like old people, although it's more common in old people. But if you're a person that's working remote from home and you don't want the vaccine and you're doing all the precautions, wearing a mask, etc., then you don't need the vaccination as much as a frontline worker does. So I'm going to stop there and ask, is there any questions?